Shall I start the meeting? I am the moderator, Dr. Pushpa.
Right.
Okay.
Okay, Dr. Pushpa.
Yeah, right.
Okay.
Yeah, so I will start the meeting. I'll introduce and then I will start the webinar, right?
Okay.
Yeah. Good evening, everyone. I am Dr. Pushpa Veerasinghe, the moderator today from the College of General Practitioners of Sri Lanka. And thank you for joining this webinar organized by the Communicable Diseases Sub Committee of the college for the World Fungal Disease Awareness Week. Special thanks to Dr. Satish, the chair of the Communicable Disease Subcommittee, for coordinating this webinar. Today we have three speakers from different fields: Dr. Surammika Eeriyagama, Dr. Wedisha Gankanda, and Dr. Naamal Jayawardena. So our first speaker today is Dr. Surammika Eeriyagama. She is the consultant dermatologist at District General Hospital, Navalapitiya. She is a council member of the Sri Lanka College of Dermatologists and a member of the Fungal Task Force. Her topic today is meeting the challenges of problematic dermatophytosis. Over to you, Dr. Eriyagama.
Thank you, Dr. Veerasinghe, and thank you, College of General Practitioners, for hosting the event because it's a very timely topic. So let me share my screen with you. Can you see my screen?
Yes.
Can you hear me?
Yes, I can hear you. I must ask somebody else. Can everybody
Anyone
hear
in the
Dr.
audience, can you
Eriyagama?
hear me?
Yes, we can. Yes, we can hear, madam. You can proceed.
Right. Okay. Let's move to my topic straight away. It is meeting the challenge of problematic dermatophytosis. Now, when I say that, some of you in the audience might wonder what is so challenging or problematic about a simple fungal infection. During our learning days, tinea used to be a very simple infection as shown by in this picture. It had this erythematous circumscribed margin and giving rise to the name ringworm, and a very simple infection to treat. It all clearly is not the tinea currently. Let me share a few of my patients with pictures with you. So this is the sort of picture that we see these days. Sometimes the lesions are so large that they involve almost half of the trunk. And if you don't expose adequately, you might actually think of this as a psoriasis or even a dermatitis, something very aggressively affected. And the book appearance of that ring-like feature is also not so common these days. You can see in the first picture that you can't actually call it a ring. And if you look at the second picture, you can see multiple rings. We call it the ring within the ring appearance. This is the picture that is produced when it's altered by various medication. So all in all, the dermatologists have recently noted change in the clinical picture of tinea. There is definitely a rise in the incidence, and unlike in the past, we see more and more cases that are chronic. And the infection is widespread, as I said earlier. And we also see a lot of relapses and recurrences. So with this concern, online survey among consultant dermatologists was conducted in 2020. People who participated, 88% of them reported that they have noticed a lack of therapeutic response to standard antifungal treatment. So you can see that this is a very concerning issue. With this in mind, we conducted the all-island study, all-island multi-centered study involving all 9 provinces of Sri Lanka in 2020, that with all 8 states. And let me share some of the results with you. This research was published recently in the International Journal of Dermatology. And according to that, these 800 patients, we treated with proper antifungal treatment in the dermatologic clinics and followed them up to 3 months. And this is the results you are seeing here. When we assessed them at 6 weeks, only 54% of them had complete clearance. And when we continued the treatment for 4 more weeks, at end of 10 weeks, even then only 62% of the patients had complete clearance. So I hope you understand the gravity of the problem. So even with proper treatment, at 10 weeks, only 62% had complete clearance. And let me show you about the recurrences. At 3 months, almost 35% of the patients who responded presented with recurrences. And actually, this figure could be higher because, as you can see, almost 1/3 of the patients were lost to follow-up. So the figure could be higher. Right. So this scenario is not limited to Sri Lanka. This problem was first reported in India 7-8 years back, and then gradually the problem spread to all the Southeast Asian countries, and Sri Lanka is just one of them. Right. So let's look at what possibly could be causing this change in the picture. So when you have a fungal infection or any infection, when it comes to any infection, the outcome depends on several factors: the organism factors, the host, the environment, and the pharmacological factors. So let's see about the organism. The change in the pattern could be due to a change in the predominant fungal species, or maybe it has become more virulent. Let's see. According to this, you can see in 1970s, the predominant organism causing tinea in Sri Lanka has been Trichophytum rubrum. And in the study we conducted few years back, you can see 65% of the patients had Trichophyton mentacrophytes, not rubrum. So what is the significance? Mentacrophytes has been reported to be an organism that is more virulent than rubrum, and also it grows rapidly. So for you to get an understanding, a small example. Now, Trichophytum rubrum can survive for less than 12 weeks in a cloth-like towel, whereas mentacrophytes can survive for more than 25 weeks. So you can see how sort of strong it is. And also, this study was done, as I said, like 3-4 years back. And at present, there is another concern because even more
Excuse me,
virulent
madam.
new genotype called, yes,
Excuse me. We
yes,
can see the full
yes.
side there. That
Can you see now?
yeah.
Can you see now?
Yes,
Okay.
madam.
Right. So currently, there is a new genotype that has been described recently known as T. indoteinae, which is even more virulent than the mentrophytes. And unfortunately, this has been reported in Sri Lanka in a study done last year. We have confirmed with molecular studies in collaboration with a German team led by a team by Dr. Primali Jayasekar of MRI. So here we have found that this genotype is also prevalent in Sri Lanka. We don't know the extent yet. So this complicates the picture. Right. Now, that is about the organism factors. Now we know compared to earlier, the organism has changed to a version that is more virulent. Let's look at the pharmacological facts. There could be a actual resistance in the organism, or we may not be giving the proper drugs, or the dosages, the timing might not be correct. Let's find out. So we did an online survey among general practitioners of Sri Lanka and we asked them what their preferred first-line oral antifungal drug was when they're treating tinea. And you can see the green color bars are for the government sector and blue is for the private sector. And you can see in both government and private sector, the preferred first-line antifungal had been fluconazole. Second had been rizovalvine. The significance of this, I will explain as we go on. And also, there are concerns about proper duration and the dosing of the antifungals. The quality of drugs, as you know, in medication, quality matters. This is especially so for antifungals, specifically itraconazole. You will understand. So in India, a few years ago, we did a study assessing the quality of itraconazole brands available in the market and comparing it to original brand. Okay. Itraconazole is a very complex drug and the factors. One is the number of pellets inside the capsule. And the other thing is the smaller size of the and the size variability of these pellets. These are technical aspects, but basically there are 3 factors that affects the quality of itraconazole that you prescribe your patients. And so when you can, I don't know whether it's very clear, but I will just mention that the original brand had a pellet count of 820 in a capsule. But if you can see in the other brands that were studied, only 11 had at least more than 500 pellets. 3 brands had less than 300. So you can see about the quality, and that is not all. Let me show you. Now, this is a microscopic sort of dermatoscopic view of the pellets, and these unusual large sort of molecule pellets that you can see scattered among the normal ones are what is known as dummy particles. So they do not contain any itraconazole, any drug at all, they are just dummies to incorporate it, fill up the volume in the lower quality brands. So you can see that although there are so many itraconazole brands in the market, the quality is like it's such a big variation in quality compared to the original. Right. In addition to that, you have to pay attention to the drug interactions as well, especially in these elderly patients who are on multiple drugs. You have to pay a bit attention to that also. But the most important thing that I want to mention is about the use of steroids inappropriately to treat fungal infections. So in our study, out of the tinea patients who presented dermatologic clinics, some of them have been treated with steroids prior to presentation to the clinic. I hope you understand what a grave thing this is. The entire outcome of, right? And in the study, this is the therapeutic response. And you can see that out of the patients who had partial clearances, the majority had used steroids prior to the presentation. Right? And the patients who have not used steroids had responded with response. And this, I don't think I included that graph in this presentation, but then the next question, we asked who have prescribed this steroids to them, whether they have got it from pharmacies, whether they have got it from Ayurvedic practitioners or from relatives, but no. Unfortunately, the steroid prescriptions have come from our doctors. So that is what I want to stress here, so that at least we can change that part of the and to make things worse, when you analyze the recurrences, you could see that the patients who had used steroids previously had a very high rate of recurrences. You all know that steroids, suppressants or immunomodulators maybe, so which even topical steroids would alter the immune response on the sites they are applied. So when you apply a steroid or a steroid combination cream to a fungal infection, that will hinder the body's ability to fight the fungus or to clear the fungus. It will, of course, settle down the inflammation, the redness, itching, scaling. It might settle the steroid, giving a false impression the patients are being cleared. So they keep on applying the steroid, further reducing the chances of clearing the tinea. And when the antifungal combinations exposed the steroid, there is high chance of them getting resistance. Right. So now going back to the original problem of adequate response to antifungals, we have identified three main issues. First one is, as I mentioned, there is a change in the predominant fungal species to a more virulent form. About that, now it has already happened. So the second factor that us, the doctors, are prescribing unsuitable drugs. I will explain what the suitable regimes are. And the third one, as you saw earlier, is the steroid misuse. So both the second and third factors change in our practice, yours and mine, as primary care physicians. I think have the most important I would share if it is suspicious of tinea. Because if you suspect a fungal infection, you may not clear out the diagnosis. That is perfectly acceptable because even to a dermatologist, sometimes the fungal infections are difficult to diagnose in the first instances because of these altered appearances. Then what I would advise you to do is give an antifungal. Giving an antifungal to eczema or any other skin condition is not going to do, but giving a steroid mistakenly to a is going to harm. So the safe option would be to use an antifungal cream or maybe a bland emollient like aqueous cream with an antihistamine for the itching if you're not sure. And then get the patient back in a couple of weeks to reassess. By that time, you will have a clear idea about the actual cause of the problem. Or if not, you can always refer to the clinic. Right. So now we have discussed about the, let's take a look at the actual management or what you should be doing. So when you have a fungal infection, there are a few factors about how long it's been there, where in the body it's involved, the extent of involvement, underlying comorbidities, etc. And also you have to think about the affordability because antifungals, as you know, are quite expensive, especially the good quality ones. So to treat the fungal infections, we have two options. You could either use topical agents or oral agents. Coming to topical treatment, honestly, unlike in the past, topical treatment as monotherapy is of extremely low value these days because topical treatments alone are not sufficient in majority of cases. It is only given in these few instances I have mentioned here. If it is just a single small patch of small duration, yes. Or if the patient is pregnant or breastfeeding, or if it's a very young child, you can try the topical. Or the other sort of significant comorbidities preventing antifungals, then there's no option, you have to give monotherapy. All other instances, you have to combine the topical with the oral agent. So about the topical agents, if you look at what is available, we have the old generation non-specific agents like Whitfield's ointment, etc. However, these are very non-specific, therefore they are not effective. In addition, they have added the skin and being a bit messy, so they are basically not promoted anymore. So what do we have? We have azoles, things like miconazole and clotrimazole, which are very effective and easily accessible, even in the government sector, and not very costly. We also have things like terbinafine topical applications or amorolfine. So if you ask me which one is best, actually there is no consensus as to which is best. There is no data to support one category over the other. So you can use whatever is available for you. And preferably twice daily applications, but even once daily would be okay. About the topicals, the thing I want you all to remember is, so if you are forced to use only topicals, make sure you prescribe adequate amounts. Now, if the patient is having about 6-7 lesions, if you just prescribe 1 tube of miconazole, that's not going to do any good. So make sure you prescribe adequate amounts and also it is now recommended to continue the treatment for at least 4 weeks after clinical cure. So tell them not to stop the application as the stops, because you stop recurrences and relapses, and also the risk of infecting the family. So therefore, tell them to use it for 4 weeks after complete cure. Right. What about antifungal soaps? It's a very popular choice. We see it quite often in prescriptions, but unfortunately, no data to support the use of antifungal soaps in the treatment of tinea. Mostly because soaps are very contact. You apply it and wash it. So the short contact time is not sufficient to make an impact on the fungus and clear it. And also the subtherapeutic exposure promotes it. So basically, antifungal soaps are an unnecessary financial burden on the prescription. So I would say there is no place for it in the current context. Okay. Then let's move to the proper treatment of oral agents. So this slide had a failure of top lesions, so and so. But put it simply, oral agents are indicated in all instances which were except which were mentioned earlier. The breastfeeding, pregnancy, single lesion, or if they cannot take oral, those are the only exceptions. So all the instances in the current scenario, tinea should be treated with oral agents. Now let us see what oral agents are available. So that is the scary part, because now we have learned that tinea has become more sort of virulent, it has become a problem, it has become chronic. So you will expect me to give new forms of treatment, something magical, something effective. But unfortunately, there is no such thing. Even today, all over the world, all we have is these 4 agents that were available for the past years. When medical studies are the antifungals we learned, and unfortunately, that is all we have even of now. Because unlike in other forms of medicine, like say antibiotics, there are so many new developments. But because fungi are such simple organisms, it's very difficult to produce new molecules, new rising infections, but we have to learn to manage this with this existing 4 options. Right. So, out of these, what I want to stress is fluconazole is not recommended for tinea. It has to be reserved for candidiasis, as microbiology strongly recommended. And the is not for tinea. So we have brisopulvine, terbinafine, and itraconazole. Mention the proper doses and durations. Surely 2 weeks are not sufficient anymore. It is 4 weeks or more. So at primary level, all right. So this is the online survey we did among general practitioners, asking their preference about the antifungal treatment. And as you can see, both in the government sector and the private, their preference, first choice antifungal being fluconazole. And as I mentioned in the previous slide, fluconazole fulvine is a second choice with very low preferences for itraconazole and terbinafine. Could be due to unawareness or could be due to the cost. So, as I said earlier, these are the proper doses, and there is no point in prescribing 1 week, 5 days, or even 2 weeks. You have to give the proper dosage, proper duration for complete clearance. And in the outpatient, like the hospital OPDs, I don't think this is possible because we can only prescribe. Then, according to the college guideline, we are requesting the ministry, it will be published soon, that in the hospitals, any fungal infections presented to the OPD, please refer to the dermatology clinic. In the general practitioner, in the practice, the general practitioners, if you are treating a tinea, the first line agents we would recommend would be griseofulvine or terbinafine for the proper duration. We prefer to retain itraconazole for case failures or maybe complicated cases. Of course, you can prescribe, but we are worried that it also might get resistance. So we are very cautious. So at the end of, after giving griseofulvine or terbinafine, if the patient is responding, then we would recommend refer to the clinic. Right. So with that, I think I can end my talk. If there are any questions, maybe we can take up later.
Dr. Eriyagama, shall I give them the chance to ask some 1 or 2 questions till before the
Yes.
next speaker takes over? Right. Anyone who wants to
Definitely.
ask any questions from Dr. Eriyagama, but 1 or 2 questions can be asked. Dr. Harun, you are not clear. Your question is not clear.
I'm sorry, I can't hear you. Dr. Pushpa, can you repeat the
Yeah, no,
question?
I
I
also
can't
can't
hear.
hear. Can you just can you type it, Dr. Harun? Till he types, anyone else who wants any other question? What are the oral antifungal used in children? There's a question.
So we can griseofulvine, itraconazole can be used according to the body weight.
Even for a
Doctor-
2 years old child, can we use?
Yes, very
Dr.
cautiously.
Harun wants to.
Sometimes the problem is usually the itraconazole capsules, they come in 100 milligrams. And when we calculate according to body weight, what we usually have to do is take out the capsule and count the pellets and measure them, usually like 1/3 of a tablet capsule. So it's a very complicated thing, but it can be given under supervision.
Madam, I have seen the patient who has not on steroid, but terbinafine 250 given for 1 month. They have reoccurred the
Yes.
tinea infection. Why is that? Is there a
The
problem?
yes, the new genotype I described, the tinea, has turned to in some instances. So that if not, about 6 weeks, 3 months sometimes, and we can double the dose with proper liver monitoring and all that.
So there are the two more
Could
questions.
be
They have,
the drug resistance.
yeah. Dr. Harun wants to know, can we combine oral medicines? The not clear question.
Yes, but it is not recommended. Yeah, we can commonly, I would do a specialist if you are thinking of combining, because there are so many instances where uh, uh, compounding factors like proper application, family contacts, relapses because of family contacts, drug interactions, all that have to be included before we think of combining oral antibiotic, antifungals. It can be done, but not at first line. Just because they are not responding within a month, don't think of combining. But theoretically, it can be done.
So the last question will be, Dr. Fernandez, what are the oral regimes for a 3 months breastfeeding lady?
3 months breastfeeding, now we will definitely stick to topicals with anti sort of histamines and maybe moisturizers, because at 3 months we will not give any orals. You have to somehow manage with topicals.
So thank you, very much, Dr. Eeriyagama, for that very informative lecture. So if there are any other questions, the college will send it to you, and then you can send the
Yes.
replies back, and then we can give them the replies. Our next,
Definitely.
yeah, thank you
Thank you
very
very
much. So our second speaker is Dr. Wedisha Gankanda. He is the consultant obstetrician and gynecologist at Base Hospital, Balangoda. And he is also a lecturer at the Medical Faculty of University of Moratuwa. Over to you, Dr. Gankanda. Dr. Gankanda. Since he is not there, shall we go to our last speaker and then we'll come back to Dr. Wedisha? Our last speaker today is Dr. Naamal Jayawardena. She is the consultant mycologist at the National Cancer Institute, Sri Lanka. The topic is prescribing antifungals in general practice, the good, the bad, and the resistant. Over to you, Dr. Naamal.
Thank you, madam. I presume you can hear me well. And
yeah, I can hear you. I think others also will be able to. Yeah.
So I will be sharing my slides. I hope you can see it as well.
Yeah.
Okay.
Yes.
So thank you to the College of General Practitioners of Sri Lanka for this opportunity. And thank you, Madam President, for the kind introduction. I'm Naamal, a mycologist at the National Cancer Institute. And I think it was mentioned that this program is in line with the Fungal Disease Awareness Week, which we are marking from October 7th to 11th of this year. So I'm going to dive straight into my talk. I know this is complicated and I'm not going to talk to you a lot about antifungals and their mechanism of action. I just want to highlight that in the general care setting, there is very few antifungals to be used. So like glycifulvine, terbinafine, fluconazole, itraconazole, and nystatin, those are
probably the only antifungals which can be prescribed in the primary care setting. I also want to highlight the fact that if you look at the fungal cell wall, you can see it's a eukaryotic cell. The fungi are eukaryotic organisms, which means that it is closer to the human, the cells, unlike the bacteria and the viruses. So which means that the side effects profile is much more marked in antifungal drugs rather as compared to antibiotics and antiviral medications. So what are the fungal infections which are commonly treated with antifungals? I think the previous speaker spoke regarding ringworm infections or tinea infections, as well as fungal nail infections. Also vaginal thrush and several types of severe dandruff require oral antifungals. So what are the challenges when prescribing antifungals? Although they are considered an antimicrobial, antifungals have some special problems. So we have very few antifungals to prescribe, especially in the primary care setting. And also, as I highlighted, because fungi are eukaryotics, antifungals are going to have more adverse effects and also drug interactions. I'll come to that in a minute. And also, they are more toxic. And also, just like antibiotic resistance, there is antifungal resistance coming up in a large way also. And also, you need to treat antifungals for fungal infections for a prolonged duration, and that comes with its own set of problems. So, what are the antifungal drugs? Like fluconazole, you can't treat it for all fungal infections. Most of the time, we will leave it for the candida and yeast infections. Yeast occurring, in the blood, in the skin. There are so many places where you can get yeast infections. So you will keep fluconazole for those. Itraconazole also is commonly used. It has similar coverage of the yeast and like candida, but also it's used for onychomycosis. Nystatin, we keep it for oropharyngeal candidiasis. And terbinafine for fungal nail infections, mostly, as well as dermatophyte infections, and griseofulvin for the ringworm infections. So before you take or prescribe antifungals to a patient, always consider whether the patient has any existing conditions that may affect the treatment. Because after all, antifungals have a lot of side effects and drug interactions. And then please check if the patient is pregnant or breastfeeding, because many of I think somebody was asking questions about pregnancy and breastfeeding. I'll come to that in a minute. Many drugs are not suitable in these categories. So what are the indications for giving oral antifungals? Extensive infections and infections that are refractory to topical therapy, infections extending into follicles or the dermis, and nail infections. So now I'm going to come to something called the AWARE classification. I'm not sure whether you know about this, but this is a new classification by the WHO, which we are going to implement or starting to implement in hospitals. So according to that, all antibiotics, antifungals, and antivirals are divided into access, watch, and reserve groups. Why am I telling you this? Because in the primary care setting, there are a limited number of antifungals which you can prescribe without having any, requiring any authorization. So I will describe what they are in a minute. So this is a circular which has been issued by the Ministry of Health regarding implementing the AWARE classification. So I'll just tell you a little bit about the classification. So what are the access antimicrobials? These are the antimicrobials, including antifungals, which have a narrow spectrum of activity. Why are we bothered about this and why are we talking about these antimicrobials? Because of the resistance. You all know that antimicrobial resistance is a big problem in the world. And so this is one step in the right direction where the drugs, the antimicrobials and the antifungals, which have a minimum potential for developing and inducing resistance, can be prescribed by anyone. By anyone, I mean a registered medical practitioner. And they have a narrow spectrum of activity, so they have a minimal potential for developing resistance. The watch group, they are only indicated for a specific and limited number of infective syndromes, and they have a more potential for developing and inducing resistance. I'm not going to go into the reserve group because they can only be prescribed and continued. They can be prescribed in hospital, but for them to be continued, they will need a microbiologist approval. So access group. So regarding antifungals, it's griseofulving and nystatin are in the access group. They can be available in all levels of healthcare institutions. And watch group and reserve group have to be prescribed and continued by specialist medical practitioners. So you have to always follow the guidelines. The latest guidelines on antimicrobial as well as antifungal use was published by the Sri Lanka College of Microbiologists this year. I hope you are all aware about it. So specifically, the watch group should be reviewed by a microbiologist or a specialist consultant within 48 to 72 hours of starting. So the spectrum of activity of antifungals is different. For example, fluconazole and itraconazole demonstrate similar activity against Candida species. However, itraconazole also has some mold activity, which means that it can be used for certain infections like nail infections. Griseofulving is useful against dermatophyte infections. Terbinafine is useful, as I said previously, for nail infections and other dermatophyte infections. Nystatin is indicated for oropharyngeal candidiasis. And I just want to stress that oral ketoconazole is no longer recommended because of its severe side effects profile. Then I will dive into some of the pharmacokinetics, which I think that you should be aware of when you're prescribing antifungals. Fluconazole, oral or IV, has a very good bioavailability. So in a normal patient who does not have something like mucositis or something wrong with his absorption, you can safely give oral because it is very well absorbed and about 90% of the drug will be available systemically. You can give it once daily. However, if the patient is having some kind of renal impairment, a chronic renal failure patient, the doses need to be adjusted. So another thing is if you're starting fluconazole and itraconazole, they need to be loaded, which means they need to be given a loading dose, which is larger than your maintenance dose. And you can see that I have mentioned itraconazole here. As compared to fluconazole, itraconazole has lesser absorption and it depends on what is in your stomach. I will come to that in a minute. So itraconazole, what is available in our country is the capsule. There is another formulation which is called the oral suspension. I think somebody was asking about children. I mean, if we had the oral suspension in our country, which we don't, it would have been easier to prescribe. But however, since we don't have it, it's a bit difficult to give children itraconazole for that matter. The other thing is itraconazole formulations cannot be used interchangeably. You cannot give the patient a capsule half of the time and a suspension half the time. They are not the same. Their bioavailabilities are different. The itraconazole capsules require food and a gastric acidic stomach for absorption. So therefore, it's better if you ask the patient to take it with a concurrent Coke or some kind of fruit juice, which will increase the absorption. And also keep in mind, if the patient is on histamine blockers or antacids or proton pump inhibitors like omeprazole or whatever, the patient will not be absorbing the drug as well. Terbinafine, because you can understand why it's given predominantly for dermatophyte infections, because it is distributed in the skin. Cresofulvin, it has to be administered with a fatty meal. So the azoles like itraconazole and fluconazole, I mean, almost all the antifungals have liver toxicity. And then so therefore you have to ask to monitor the liver function test. For example, if you're giving it for a long duration, it's better if you can ask them to monitor it like once or twice weekly. That should be more than enough. And if you give, and another thing is itraconazole, it's better if you don't give it to a patient who is having heart failure, because it will precipitate it. I mean, it will worsen it. So terbinafine also can cause elevated liver enzymes. It can cause agranulocytosis and bone marrow suppression. So please monitor the full blood, the white cell count, and do full blood counts to monitor for that. So cresofulvin, it has a very toxic profile. As you can see, it has photosensitivity. So, I mean, you have to always advise the patient to avoid exposure to intense sunlight. And then again, here also bone marrow suppression has been noted, as well as liver impairment. I think somebody was asking about pregnancy and breastfeeding. So fluconazole as well as itraconazole cannot be given in pregnancy. Why? Because they have been associated with abortions. And in addition, fluconazole has been associated with congenital malformations, such as heart malformations. So please do not prescribe fluconazole in a pregnant lady. And also, fluconazole is not recommended in breastfeeding women as well. Cresofulvin is contraindicated in pregnancy as well. Females should be asked to use effective contraception if you are using cresofulvin during therapy, and men should be asked to avoid fathering a child for at least 6 months after therapy if you are prescribing cresofulvin. The evidence is not as strong in terbinafine and nystatin. There are not enough studies, so I'm not going to really dive into it. But however, avoid unless necessary. I mean, if the lady is pregnant, you can always delay treating it until the patient, until the lady has completed her pregnancy. So drug interactions is a big problem in antifungals. So always be aware when you are prescribing azoles like fluconazole, always ask the patient what are the medications they're on, because it can lead to a lot of problems with interactions. Because the azoles are metabolized in the cytochrome P450 system, all the drugs which are metabolized in the same system will lead to a lot of problems. So these problems can be, like, for example, always check if there are other concomitant medications which will increase the QT interval. Be careful when the patient is on anti-diabetic medications because it can lead to hypoglycemia. Things like warfarin, the prothrombin time can be elevated. So always check the drugs. Then I just want to, I don't think I need to go into this because the previous speaker spoke about it. So single lesions can be managed with topical therapy, and oral therapy has obviously broader side effects profile as compared with topicals. So the oral treatments for dermatophyte infections are terbinafine, itraconazole, and cresofulvin. You do not give fluconazole for dermatophyte infections. And again, do not use steroids for dermatophyte infections. It can induce topical steroid-induced skin atrophy, and treatment failures have been reported. And also overuse can lead to the emergence of resistant dermatophyte infections. These are my last few slides. It's very difficult to treat a fungal infection. Why? Because one thing is because of antifungal resistance, and because the patient has to be on long-term antifungals, there's poor adherence. And most of the fungal infections are due to the patients due to some kind of immune suppression. So you have to always see if you can reverse that. And as I said, there's a lot of antifungal pharmacokinetics like poor absorption, side effects profile, and interactions. So you have to be aware of that. And lack of source control. I don't think that applies to the GP setting, but it's kind of very difficult to treat a fungal infection. Antifungal resistance. There is something called primary resistance, where the fungus is intrinsically resistant to an organism. And secondary resistant, where it has developed resistance due to exposure to antifungal agents. So this is complicated by the limited availability of susceptibility testing. Even in Sri Lanka, currently, we don't do antifungal testing for all the available organisms. So it's sometimes difficult to distinguish between whether the patient is not responding due to clinical drug resistance or something wrong with the organism, or whether we got the wrong diagnosis. So my take-home points is the choice of antifungals in the primary care setting is very limited. Be mindful about the spectrum of activity and antifungal resistance. You cannot give one antifungal for every fungal infection. Always check for drug reactions. And the mycologists, there is quite a few of us now. We are always very happy to help you. So please do contact us if you have any questions. So that's all I have for you. Thank you very much for your kind attention.
Thank you, Dr. Naamal, for that very informative lecture. So 1 or 2 questions can be allowed. Is there any questions from the audience?
Madam, is there any added advantage when we are using the topical in a different type and oral in a different, like terbinafine, topiral, and itraconazole oral?
Yeah, I think that is actually because it's 2 different mechanism of action. So therefore, it is actually what is used. I think Surammika will be able to tell more. But since you're using 2 different antifungals with 2 different mechanisms of action, it's what we do. It's recommended. Yes. So trying to stop sharing, but
there is another question from another participant. What about tropical therapy in pregnancy?
yeah, that is fine. Topical therapy is what should be done in pregnancy, because otherwise the patient will have giving systemic antifungals. It's contraindicated. So there is no contraindication to use in topical therapy in pregnancy.
So, okay, Dr. Naamal, thank you very much. So we'll go back to the second speaker. Our second speaker, he will be the last speaker, is Dr. Wedisha Gankanda. He is a consultant obstetrician and gynecologist at Base Hospital, Balangoda, and also a lecturer at the Medical Faculty of University of Moratuwa. Over to you, Dr. Gankanda.
Hi.
Dr. Gankanda, can you hear me?
Yes. Can I share my presentation? Am I a
Yes.
host?
Yeah, I think you have been allocated.
Okay, give me a few minutes. Hi, I get a message saying disabled participant screen sharing.
Wait, 1 minute, I will call the.
Still I can't.
Yeah, sorry.
Hi. Can you see my presentation now? Yes, we can. Okay. Good evening, everyone. I'm Dr. Wedisha Gankanda. I'm currently the
Yeah,
consultant.
screen sharing back to work. All right.
Right. Currently, I'm the consultant obstetrician gynecologist at Base Hospital, Balangoda. Thank you very much, the College of General Practitioners and the Microbiology and the Mycology Colleges for giving me this opportunity. In my lecture, practically, I want to share the practical tips that we follow when treating patients with usually vaginal candidiasis. I have named this lecture as so common yet so unknown because every day we see so many patients who have been not treated or suboptimally treated, who are having vaginal candidiasis and having a very poor quality of life. So as general practitioners, it's your duty to detect patients who have risk factors or who have the early symptoms and suspect that they may be having vaginal candidiasis and refer to the relevant people. If you can't treat the disease, so you can start the treatment by your own. There are good things prevailing in this country. One of that is there are guidelines produced by joint exercise by the College of Obstetricians and Gynecologists and the Microbiology. So you can easily find them on the internet. I will give you the references. During my lecture, anyone can come up and ask your questions. Right. So my lecture outline will be like this. I will be focusing on the common topics like the symptoms, how to diagnose, and the risk factors and the management principles. Mainly my focus will be on the suspicion and the diagnosis of the disease, and the management is quite straightforward, and the resistant cases and tricky cases we always take the advice of the microbiologist, or in severe cases maybe a mycologist. So I think it's our duty as primary care practitioners to suspect and detect the cases as soon as possible. Right. So, for your reference, the vaginal candidiasis is a yeast infection. So, it's one of the commonest infections affecting most women of reproductive age. So, it's said at about 75% of the women will experience at least one episode of vaginal candidiasis in their lifetime. And further, about 45% of them will have 2 episodes. So you can see how much prevalent condition this condition is. You know, there are guidelines produced in UK called British Association of Sexual Health and HIV. We follow that guideline for genital tract infections. There, we categorize this vaginal candidiasis into 2 categories. One is acute vaginal candidiasis. The other category is recurrent vaginal candidiasis. So in recurrent, you might get about 4 episodes per year, although we don't regularly try to diagnose candidiasis. In those countries, they usually do bedside test and diagnostic test, and they say at least 2 episodes should be confirmed vaginal candidiasis. Right. So this is the most important slide of this presentation. So as general practitioners, you might get people who complain of some other infection. You know, the typical symptom of vaginal candidiasis is passage of whitish vaginal discharge. Our people say sudhyano, or some people say anga unu karala yano. Right? So when you say vaginal discharge, it's very important to ask about the nature of the vaginal discharge. But because the vaginal candidiasis is the commonest, one of the commonest reasons for vaginal discharge in reproductive age, you might suspect vaginal candidiasis. That's not a problem. But sometimes they might come with some abnormal symptom, not very commonly known as the symptoms of vaginal candidiasis. So, for example, itching, redness of the areas like vulva or skin creases. Or sometimes they will just say there's a pain during intercourse. Because during vaginal candidiasis, the normal lubrication of the vagina is lost. And you might get a burning sensation. And there can be associated urinary tract infection. So they might say there's burning sensation while they are passing urine, and a general practitioner might not examine the patient and just do a urine flow report, or even without a urine flow report, might treat for a urine tract infection. But you have actually missed the vaginal candidiasis, and the patient might come again and again saying, I'm having dysuria. And some patients, they go to a different doctor, and that doctor also treats with another antibiotic for urine tract infection, but the underlying cause of vaginal candidiasis is missed. So my special urge to general practitioners is always ask about uncommon symptoms of yeast infection as given in this poster. These posters are actually produced in UK to disseminate among general practitioners to remind over and over to look for these kind of uncommon symptoms like soreness, redness, swollen vulva, irritation, and maybe itching. Right. So when we examine, this is what you see. So I'm going to talk a little bit about this one. Examination is a must. We have seen in general practice, most of the times, people don't bother to examine patients for several reasons. One is they don't have enough facilities. So to do a vaginal examination properly, you need to have a proper bed, a chaperone, a proper light source, and usually a clean or sterile speculum. But and it takes time to undress and to place the patient and get the patient out of bed. It might take another 3-4 minutes. So in a busy outpatient practice or a private practice, you might not have that much time. But the information you get by examining the patient is massive. So my only urge to general practitioners are, whatever the genital symptom patient is complaining, please spend some time looking at the vulva of the patient and doing a speculum examination if possible. And if you don't have the facilities, please refer the patient to the nearest hospital gynecology clinic. Right. So, when you examine the patient, sometimes you might see the features of infections or inflammation in the vulva. And I don't know whether you remember, but some conditions like the whitish discoloration of the vulval skin or some inflammation-like conditions might be actually vulval cancer or precancerous lesions like lichen sclerosis. So always have the habit of looking at the vulva, and if you think this doesn't look normal and this is not straightforward vulvovaginal candidiasis, please refer the patient to the nearest gynecological clinic or the dermatology clinic so that they will look at the vulva properly, and if they have any suspicion, they will take necessary, sometimes skin biopsies. And you might save a life of a patient who's developing the initial stages of vulval cancer, which is curable by doing a simple vulvectomy. Okay, and when you look at the look through the speculum, the cervix, you might, in addition, you will see the polyps, the unhealthy cervixes, or sometimes cervical cancer, and pelvic inflammatory disease causing purulent discharge, and so many things. So always take your time to do a speculum examination. Right. So when you look at the speculum, and you will see this curd-like discharge, which is typical of having vulval candidiasis. And usually we treat the patient clinically. So when you see this typical discharge, you treat the patient with the first-line medications for vulval candidiasis. And I think the other speakers have elaborated on the treatment options and the interactions and all the details about the medication. But I'm specifically talking about pregnancy. Usually, oral antifungals are not given in pregnancy, at least in the first trimester, but usually throughout the pregnancy, we don't give it because of the problems we earlier discussed. I was listening to the lecture, the teratogenicity and miscarriage risks. So we usually treat with the topical antifungals, miconazole usually, and for the we have the pessaries, and for the skin creams I will talk about later. So always look at the discharges. If you have any suspicion, there are other tests to perform. Then when patients complain about any discharges, always think about the risk factors. Vulval candidiasis is a marker of immune suppression. So HIV patients will have recurrent vulval candidiasis and vulvovaginal candidiasis and oroesophageal candidiasis and disseminated other fungal infections. So always think about immune compromised status like uncontrolled diabetes. If the patient is having type 1 or 2 diabetes for a long time with poor control, they are at higher risk of having fungal diseases. And pregnancy itself. Pregnancy is a immune suppressed condition. Why? Because the baby inside is formed of maternal and paternal genetic material. So the baby has some foreign genetic material. To tolerate that genetic material without rejection, the mother's body has developed some reduced altered immunity during the pregnancy. That is why some of the immune conditions like rheumatoid arthritis or even bronchial asthma can subside, which if they are autoimmune conditions, and some cancers will spread during the pregnancy very fast due to this immune modulation. And hormonal changes also cause a risk factor for vulvovaginal candidiasis due to estrogen acting on the vaginal cells and causing changes in the pH and the normal flora. Then antibiotic use. There's a lot of antibiotic prescription, not only by the primary care physicians, but these days people directly go to pharmacies and they buy antibiotics, and the pharmacist sometimes they give the strongest antibiotic without any rational indication. So unnecessary antibiotic use can also change your normal flora and put you in more risk of having yeast infections. Right. Then steroid use also can reduce your immunity, and always think about candidiasis in patients with chronic steroid use. Right. So when we talk about diagnosis, it is usually a clinical diagnosis, but rarely we will have to confirm them by laboratory tests, especially if they have recurrent infections and or if they don't respond to the normal first-line medications. So always you have to discuss it with a specialist in microbiology before treating by your own. So these are the tests which are usually useful to diagnose vaginal candidiasis. Microscopy which will show the typical appearance of fungal hyphae and spores. And pH testing, you know, the normal vaginal pH is like around 3.5. 3.5 to 4.5, and usually this is maintained because of the lactobacillus activity. They produce the acids. But when the hormonal changes are there, this lactobacilli will reduce, and the other bacteria which are producing more basic fluids will be there, so the pH will rise. So one of the tests you can do is pH testing, but these are very, very rarely performed in Sri Lanka. And KOH test, which is also called WIF test, this can be used to differentiate this from vaginal bacterial vaginosis and vaginal candidiasis. And in the microscopy, adding KOH will show a typical appearance of the candida. And very rarely, we can use fungal cultures if they are especially resistant or having recurrent episodes. And although we just say it's vaginal candidiasis, there are subspecies of candida. Sometimes it's very important to detect which subspecies of candida is there to effectively treat patients. So these are the pictures of KOH test, the microscopy and the cultures. Right. So when you have a vaginal discharge, whitish vaginal discharge usually, apart from vaginal candidiasis, you have to think about other conditions like bacterial vaginosis, trichomonas vaginalis infection, dermatitis, allergic reactions, and not only those things, even vulval or cervical cancers or dermatological conditions. So these three conditions we always think about as gynecologists: bacterial vaginosis, trichomoniasis, and candida vaginitis. The nature of the discharge is quite different. So in bacterial vaginosis, you get thin off-white discharge with typical fishy odor. So they are very smelly. But when you look at the vagina, there's no inflammation. That's why it's called vaginosis. In trichomoniasis, you get thin yellowish green frothy discharge. It's very copious with air bubbles. And there is vaginal inflammation. In candidiasis, we get thick cheese-like discharge with inflammation and sometimes the redness spreading around the vulval areas. And in the microscopy, you can see clue cells in the bacterial vaginosis with high pH, and this motile trichomonas in the trichomoniasis, and this yeast-like hyphae in vaginal candidiasis. The most important point for general practitioners is to ask about the nature of the discharge, whether it's a profuse one or thin, scanty one, whether it's a smelly one or not, and directly ask whether it's like a cheese or curd-like, and ask about the surrounding skin, whether they are itchy, reddish, and always do an examination. Right. Then when we think about the management, there are general management and specific management. So general advice is general vulval skin care to avoid irritants like hard soaps, because sometimes when they are itching, they might think applying soap vigorously will clean the area, but actually it will only worsen the problem. Then in treatment, we have uncomplicated vaginal candidiasis, severe vaginal candidiasis, and recurrent vaginal candidiasis. But I think from our level, we should only think about treating the uncomplicated vaginal candidiasis with oral fluconazole or clotrimazole, or you can use topical treatment like vaginal pessaries. You know, there are some common brands which have, let's say, Mycorrhiza, Candid. They have 500 milligram once a day regimes, 200 milligram 3-day regime, and 100 milligram 6-day regime. So according to the situation, we can use that. For example, during pregnancy, let's say a mother comes around 39 weeks with severe vaginal candidiasis, and we only have 1 week for the delivery. So what we can use is maybe 3 days regimen. But if they are quite close to the delivery, we might need 500 single dose. I'm not quite sure whether they are equally effective in the efficacy, but as clinicians, we tend to use the longest regimen with lowest dose so that we think it's more, it gives more sense to treat the condition. But sometimes we will have to use 1 or 2 treatment cycles to get the best result. I think apart from the uncomplicated vaginal candidiasis, for severe vaginal candidiasis and recurrent vaginal candidiasis, always take the advice from the microbiologist. And if they detect any non-candida albicans species, always take the advice regarding the use of other medications like this nystatin or amphotericin. Right. So these are some of the commercially available antifungal medications that we routinely use every day. So when prescribing these medications, just write in the prescription and ask the patient to take the medication for 1 day, 3 days, or 6 days, not enough. It's very important to show the patient what is this like, because sometimes these patients have never used a vaginal pessary and they are quite reluctant to use it out of shamefulness. So you can say, this is not only you that you are having this condition, so many people are having the same condition and it's very common, right? And always tell a pregnant patient, these treatments are not going to the baby. These are only topical, just like you apply some cream on your skin when you have some pain. So, and tell them this will directly act on the focus of the infection. Then they are convinced. And take one of the tablets and put them in the applicator and show them this is how you put this in the applicator and this is how you push it inside the vagina. And even we tell them the uterus, we tell them the uterus is not open to the vagina. There is something called cervix which is closed. So even if you push this inside the vagina, it will not go into the baby. There's the closed cervix preventing anything going inside. So that much of level of information is needed for the patients to be persuaded to insert these into the vagina. Right. Then if you have skin diseases, you can use the cream always. Right. So these are some of the preparations we use, and I have shown you sometimes we get cultures as well for the patients who have discharges. So this is one of the culture reports we have recently got. Right. So there are few things that we usually don't think about. One of that is, although this is a common condition and we see so many patients, this could be a very embarrassing and a stressful situation to the patient, especially if they are pregnant. They might think this is a big problem and the babies might get affected, and they might just do an internet search to ask somebody, I have a fungal infection, whether to treat this or not, and they might come across, okay, fungal treatments are bad for babies, they cause teratogenesis, and they might not even take the medication. I have had at least 20 or 30 patients who have come asking for induced abortions just because they have taken antifungal treatment during the past few months, and they have just recently found out that they are pregnant. So they want us to do a termination because they are quite convinced that their babies might be having anomalies. But in those circumstances, we tell them, although these are not recommended in the pregnancy, these are not indications for termination because these risks are not very high, right? And we tell them our personal experiences, saying we haven't seen anybody who's having anomalies just because they had an antifungal treatment. Because there are so many people who are trying to have abortions, unwanted pregnancies, and we haven't come across anybody who has taken antifungals and had an abortion. Right? So when you take your time and try to explain them, only they convince and they realize, okay, that's quite okay. So we will just look after the baby and we'll do anomaly scan and continue the pregnancy. Right? So like that, for these treatments, there may be a big social stigma than you think. And anybody won't like to insert anything into their vagina because they think it's quite uncomfortable and embarrassing. But when you explain them the advantage of using a vaginal therapy rather than oral therapy, they easily get convinced. What I usually take one of the examples, which actually I created this myself. I'm telling them, if you want to send some medication to the vagina, if you take it orally, that will go to your brain or heart or the skin or everywhere. So let's say you take 100 milligrams or something, out of that 10 milligram will go to your vagina, but all the 90 milligrams might go to the unnecessary unwanted places and give you side effects. So but if you give same thing vaginally, that all the 100 milligrams will go to the vagina. So what do you prefer? To give to directly to the same place, or you give it systemically so that only a portion of the medication will go to the intended place? Then the patient will understand, okay, topical treatment is better, and the patient agrees to do the topical treatment, right? Then think about glycemic control, because there can be undetected diabetes. So take your time to do a fasting blood sugar. And if you think this patient might look like a diabetes with the symptoms and things, straight away ask for HbA1c as well. So you will see what is the sugar control like. And don't forget to suspect anybody who's having recurrent vaginal candidiasis about the immunocompromised situation like HIV. Right. In conclusion, this is a quite common and treatable condition, but we have to actively search for the risk factors and diagnose, and always refer to the SSUG guideline if you have any doubt, and get involved the microbiologist for the opinion. Right. I have included here when to see a doctor for discharge. This is to detect any unusual infections or cancers or anything. So always ask the patient these key questions and tell them, or you can display this as a banner in your practice to tell them to increase, if you have any increase in discharge, change in color of the smell, or any blood stain discharge, pelvic pain, itching or burning sensation, or painful sex, always go to a doctor, a gynecologist, or at least a general practitioner, and get yourself checked. So this is the key message you have to give, because many people are quite confused with whatever the discharge they are having is natural or abnormal. So this is how you tell them to detect any abnormal discharge compared to a natural discharge. Right. One more point I have to tell you. When you are doing speculum examinations, always try to use water-based lubricant or some normal saline, because sometimes when you take the swabs for cultures, the lubricant might cause inaccurate results. And one more thing, if you have any doubts that the patient is having other infections than this yeast infection, always think about treating the bacterial infections and the viral infections as well. So best thing is to refer the patient to the nearest STD clinic, where they will not only look for other infection, but they will treat the partner and confidentially take the partner tracing information and inform the other sexual partners about that possibility of having other sexually transmitted diseases as well. Right. So thank you again for listening to my lecture, and I'm open for any questions related to this.
Thank you, Dr. Gankanda, for your very informative lecture. And any questions, please? So there is a question from a participant: how to treat vaginal candidiasis in unmarried women?
Okay, so the medications best will be described by one of the mycologists, but what I can tell you is you are thinking about the intact hymen, right? So in our experience, when we inspect so many girls unmarried, the hymen has penetration. So you can easily insert a medication through the holes in the hymen, and they are dissolving. They are not very hard. So you can ask them to insert the pessary. The inserter is also very small, carefully, or you can insert it yourself. But if they are not, very much comfortable with that, you can always use the oral medications. And there's no limitation to use any oral medication, because they are unmarried and they are not pregnant. So when you are treating with oral medications, you can ask them to avoid pregnancy for at least 1 month after using this medication.
Okay. Thank you very much, Dr. Gankanda. I like to know whether because there's a question from one of the participants. I'd like to know whether Dr. Eeriyagama or Dr. Naamal is still online.
Yes, I am here.
Now he says that Dr. Eriyagama told about the quality of different brands of antibiotics.
Yes.
But telling the brands are not ethical. So
Yes.
can you all ask what could be done about this issue with the inferior drugs, with the substandard brands, and what is the role of the professional colleges to get rid of them? This is from a college member.
Yeah, the College of Dermatology Council and the Fungal Task Force have been working on it, but it's a very difficult and uphill task because we don't have much say in this brand registration. And there is no facilities in Sri Lanka at the moment to test the quality. They are sort of very technological labs. So we recently also had a deep discussion with the ministry, and we educated them about the problem, and possibly we could start on quality checks later. But at the moment, I don't think there's anything we can do like in a short-term basis, I'm afraid.
Can I add a word to that? I'm
Yeah.
Naamal. I just want to say, yes, I do agree with Dr. Surammika that that's a problem with the brands. But another thing that you can do is what we have is the itraconazole capsule. So when you are prescribing, always give the patient information so that they can optimize the drug can be optimally absorbed from the GI tract. Like tell them to take it with a meal or at least within 1 hour of having your meal, and to kind of take a fruit juice along with it so that you can optimize your absorption and to stop any omeprazole or pantoprazole or ranitidine or whatever H2 blockers that the patient is on, so that you can optimize the absorption as much as possible.
Right. Okay, thank you very much. And thank you, Dr. Eeriyagama, Dr. Gankanda, and Dr. Naamal Jayawardena for the very informative lectures. And thank you very much for all the participants. So good night to everyone.